Good afternoon, everybody, and welcome to the GANSID Congress 2023. My name is Professor Jennifer Knight-Madden, and I am from the Sickle Cell Unit in the Carribean Institute for Health Research in Jamaica at the University of the West Indies. So as a member of GANSID, I'll be moderating today's session and a panelist. And there are two of us, and I'll introduce Dr. Ikolo shortly. So just going through a few things. The good news is that this is all going to be recorded. And so if you miss some of it, or if your colleagues would like to see it, they can go to the website inheritedblooddisorders.world and be able to watch the webinar. So this particular workshop is about the Caribbean. And we'll be talking about sickle cell disease and inherited blood disorders in general. So Dr. Ikolo will speak, and then I will speak, and then we'll have lots of time for your questions to be answered and to just have a rich discussion about the topic. So there are some housekeeping rules. The first thing is that the questions, the thoughts, and so on will be taken after the two presentations. So make a note of them. You can put them in the Q&A, but we won't be pausing during the presentations to take questions. Your microphones will be muted throughout, but if you need to ask a question, you can put up your hand or put it in the chat, the Q&A. If your primary language is not English, please go ahead and make use of the translations that are provided, the captioning that is available. So if you are not, if you haven't done that before, let me tell you how to do it. You click the show caption at the bottom of your Zoom screen, check the enable translation box, and choose the language that you want the caption to be translated in. So you will see the text that comes in your language. All right, that's great, as we have many languages in our region. So throughout, we're going to use respectful language in the chat, and we're not going to post any unrelated materials to today's discussion. So we're going to stay on topic. Okay, so let me just see. We're now at 5 past, so we're ready to get into the meat of the matter. And thank you to those attendees that are here and are on time. It's going to be a rich 1.5 hours talking about the situation in the Caribbean. So it's now my pleasure to go ahead and introduce to you, if you don't know her already, Dr. Felicia Ikolo, who is an associate professor in the Department of Biochemistry. And this is at the St. George University in Grenada, St. George University School of Medicine. And her doctoral research was in proteomics in the Northumbria University in the UK, and her research interests include genetic diseases, and sickle cell is one of them. She's a fellow of the Institute of Biomedical Sciences UK and a member of the Caribbean Association of Medical Technologists. She is also, and this is very relevant to today's talk, a member of the Sickle Cell Association of Grenada. So I am going to ask Dr. Ikolo to share her slides and to go ahead and give the first talk during this session. Thank you so much.
Thank you, Dr. Knight-Madden. Thank you so much. And welcome again to everyone. Let me find my pointer. All right. So welcome to each and every one of you. I'll be talking about the challenges, the triumphs, and the next steps for patient organizations and patients with hereditary blood disorders in the Caribbean. I have some co-authors. We've come together to put this presentation together. I've listed them up here on the slide. I will go ahead with the presentation. I want to start off by listing some. I will say this list is not exhaustive. That means there may be some other blood disorders that are not listed here, but these are some common hereditary blood disorders you will hear about in the Caribbean. Sickle cell disease, the thalassemias, alpha and beta thalassemias, hemophilia, glucose 6-phosphate dehydrogenase deficiency, you will hear a little bit about, not too much, as well as von Willebrand disease. These are some hereditary blood disorders you hear about in the Caribbean. I want to start off by talking about some international patient organizations that serve those who are affected by hereditary blood disorders. And they serve those affected in the Caribbean, although they are international patient organizations. One of them is GANSID, the Global Action Network for Sickle Cell and Other Inherited Blood Disorders, who is responsible for organizing this Congress that we are attending today. Another one is the Global Alliance of Sickle Cell Disease Organizations. This was registered in Canada. GANSID was registered in the United States of America. We also have Thalassemia International Federation, which was registered in Cyprus. However, different countries came together to individuals from different countries like Greece, UK, USA, Italy, including Cyprus. They came together and eventually this was registered in Cyprus. We have the World Federation of Hemophilia, which was actually established by Frank Snabel, who was born with severe hemophilia. This World Federation on Hemophilia was registered in Canada, however, it's serving different parts of the world right now. So these are some examples of international patient organizations that serve those who are affected by hereditary blood disorders. I want to point out some regional patient organizations, those we find in the Caribbean region. One of them is the Caribbean Network of Researchers on Sickle Cell Disease and Thalassemia, CAREST. Another one is Sick Kids Caribbean Initiative, Sickle Cell Unit in Jamaica. These are some regional organizations serving those who are affected in the Caribbean region. Apart from these regional organizations, we have some country-specific organizations. For example, we have Belize Sickle Cell Association, we have the Sickle Cell Association of Grenada, we have Sickle Cell Support Foundation of Jamaica, we have the Society for Inherited and Severe Blood Disorders of Trinidad and Tobago, we have Foundation Pierre Fabre in Haiti, Hope Foundation in Barbados, Hemophilia Society of Jamaica. Like I said earlier on, the list is not exhaustive. There are some other associations in some other parts of the Caribbean, and even in these countries listed, they may have some other associations or organizations who have not listed here. I hope we'll be able to, when we are having the question and answer session, you can tell us where you come from, the association you belong to, if you belong to any association, serving those who are affected by hereditary blood disorders. Today, we are talking about the triumphs, the challenges, and the next steps. In talking about the triumphs for the patient organizations who serve those affected by hereditary blood disorders, I'll take two examples. First of all, CAREST, the Caribbean Network of Researchers on Sickle Cell Disease and Thalassemia. This organization has been able to put out presentations for regional governments to advise regional governments on policies on how to better serve those who are affected by sickle cell disease and thalassemia. They have had such presentations for regional governments in different parts of the Caribbean. CAREST has also offered subsidized screening for a 2-year period to policymakers in different parts of the Caribbean, although the response from country to country varies. CAREST has partnered to initiate universal newborn screening in some Caribbean countries like Tobago, Grenada, St. Lucia, Jamaica, Haiti, and Antigua. CAREST has been involved in training medical professionals, especially in Grenada and Antigua, in the management of those affected by sickle cell disease. CAREST has also been involved in updating clinical care guidelines for management of those affected by sickle cell disease. And CAREST is involved in facilitating research programs across the Caribbean. And from such research projects of CAREST, we have had exchange of intellectual abilities across the Caribbean region, resulting in several publications in peer-reviewed journals across the world. Another example of the triumphs for these organizations that cater for those who are affected by hereditary blood disorders is the Sick Kids Caribbean initiatives that we have in 6 Caribbean countries. I specifically pointed out 6 Caribbean countries to bring to limelight the fact that these organizations may be functioning in the region, but sometimes not all the countries in the region may have been reached out to or may be receiving benefits from these organizations. And this may be because of funding, which is one of the constraints that we face in the region. The Sick Kids Caribbean initiative has improved access to services for children in the Caribbean with cancer and blood disorders. It has also increased capacity for Caribbean partners and strengthened infrastructures to enhance how we care for children who suffer from cancer and blood disorders in the Caribbean. And by doing this, other users of the healthcare systems in the region benefit from the activities of Sick Kids Caribbean initiative. And the Sick Kids Caribbean initiative also tries to encourage exchange of information in the region. I want to talk a little bit about some model country-based programs in the region, some model country-based programs. One of them is the Sickle Cell Unit in Jamaica, which is the only comprehensive sickle cell center in the English-speaking Caribbean. The core functions for this sickle cell unit is healthcare research and training. Another model country-based program is the National Medical Genetics Center in Cuba, which was initiated in 1983 and embarked on mass education, screening, and genetic counseling, care of those affected by hereditary blood disorders, and they also have prenatal diagnosis. I have a case study to talk to us about briefly. The case study is Grenada. We know that sickle cell disease has been around for thousands of years, but it was only in 1910 that Dr. Herrick in the United States of America described to the whole world the presence of these banana-shaped sickle red blood cells, which he discovered when he was looking through the blood of a young Grenadian dental student in the name of Walter Clement Noel. He traveled from Grenada to the United States to study. He was sick, and when his blood was examined, Dr. Herrick saw the sickle-shaped red blood cells. That was the first time sickle cell disease was described to the whole world. Walter Clement Noel came back to Grenada to practice as a dentist and died in 1916. He's buried in St. Patrick's in Grenada. This is just to bring to us how long sickle cell disease has been described to the world. Right now, treatment and research into sickle cell disease has improved over the years. The life expectancy and general well-being of those who are affected has also improved. Affected individuals are living longer. However, despite the fact that sickle cell disease has been around for years, has been described since 1910, we have worldwide challenges. Worldwide challenges exist. And it is because of these challenges that we have country-based programs like the Sickle Cell Association of Grenada that aims to use all available resources to promote public awareness of the disease, sickle cell disease, and encourage the development, implementation, and evaluation of a comprehensive sickle cell program for all those in the country. And for this reason, we have volunteers who make up the executive board, for example, of Sickle Cell Association of Grenada. In Grenada, the chairperson is Mrs. Anne David Antoine, supported by other volunteers. So we have volunteers working in these different organizations, both country-specific organizations as well as regional and international organizations. To support the work of Sickle Cell Association of Grenada, for example, the association is collaborating with St. George's University in the area of research. And we have faculty in St. George's University who encourage students, because the students are the future, encourage students to participate in the activities of Sickle Cell Association of Grenada. Some of the challenges we face in the region is that some of these international regional organizations have limited coverage in terms of reaching all the Caribbean countries. And newborn screening for sickle cell disease or even early childhood intervention is not universally available in all Caribbean countries. We have in some Caribbean countries, like in Jamaica we have, in Grenada we have, but finance has been, funding has been an issue. There's lack of specialized patient care centers in some Caribbean countries, where you have specialized centers to care for those who are affected by hereditary born blood disorders. And one of the greatest difficulty is funding. Not only limited funding to set up and continue the specialized patient care centers, but limited funding for research and development. What is the next step? For those who are affected by hereditary blood disorders and the patient organizations, I want to encourage advocacy for the implementation of newborn screening in all Caribbean countries, training and workshops to improve the care practices across the region, mass education, screening and genetic counseling, including prenatal diagnosis, newborn screening, and screening of the general population as a whole. For the general population, such screening can be done in form of health fairs, reaching out to schools, reaching out to churches. Such screening can go in that direction. Also, for next steps, dedicated patient care centers should be set up in all Caribbean countries to take care of all those who are affected. There should also be workplace supportive policies so that those who are affected by these hereditary blood disorders may have support at their workplace. If they have to miss work, for example, there should be support for them. Counseling. Funding for research is another area where I will say this is one of the next steps, because if we can improve on research that is already here in the Caribbean, then we'll make more headway. Funding to support the effort of patient organizations, country-specific patient organizations, regional patient organizations, as well as international patient organizations. This will go a long way in making life better for all those who are affected by these hereditary blood disorders. And finally, what will take care of it all is by the time we have a universally available cure for these disorders we are talking about today. Think about sickle cell disease that has been there for thousands of years. But the cure for sickle cell disease is not universally available. Gene therapy has been successful in treating a few individuals, for example, in the United States of America, who suffer from sickle cell disease. But because of the cost of this treatment, it is not universally available. And because of the fact that it's still early, for example, in 2019, Miss Victoria Gray was treated for sickle cell disease, was cured of sickle cell disease using gene therapy in the United States of America. But this is still in its infancy. We now have a cure which is being tried, clinical trials for thalassemia, beta thalassemia in the United States of America. By the time such cures will be available in terms of costs, when they will be made available to all those who are affected, then we'll say, yes, we have gone a long way. So challenges still exist. A lot of strides have been made, but we still have a lot to do to make life better and easier for all those who are affected by these hereditary blood disorders in the Caribbean region. So I want to thank you all for your time. And I also want to thank my fellow authors, Dr. Thomas, Dr. Idris, Dr. Taylor, Mr. Ikolo, Dr. May, Mrs. Anne David Antoine of Sickle Cell Association of Grenada. And I also want to specially thank all members of Sickle Cell Association of Grenada for how we have worked together over the years, and even in putting this presentation together, for the encouragement. And finally, I want to thank all of you. Thank you for your time. Thank you.
Thank you, Dr. Ikolo. Very interesting and quite comprehensive. So we thank our attendees. We ask that if you have any questions arising out of this first talk, that you can go ahead and put them in the Q&A or in the chat, and we will certainly get to it at the end of the next presentation. Thank you. I hand back over to Dr. Ikolo.
Yeah, thank you, Professor Knight-Madden. Thank you so much. Thanks to all our attendees. You're welcome again. I would like to introduce our next presenter in the person of Professor Jennifer Knight-Madden. Dr. Knight-Madden graduated from the University of West Indies Medical School. She completed her training in pediatrics at the Hospital for Sick Children in Toronto, and a fellowship training in pediatric pulmonology at Duke University Medical Center in the United States of America. She also completed her Master's of Science degree in biometrics from the same university, Duke University Medical Center, and she completed her doctorate degree in clinical research from King's College, London. Professor Knight-Madden has published several papers, several books, and she has published in more than 60 papers in peer-reviewed journals. She's an active member of several local in terms of Jamaica, where she resides, regional organizations as well, like the Caribbean Network of Researchers in Sickle Cell Disease and Thalassemia, CAREST. She's the vice president. She's an active member of other organizations, and she's an honorary consultant at the University Hospital of the West Indies. Dr. Knight-Madden is a proud graduate of St. Andrew's High School for Girls, and she's a recipient of the St. Andrew's High School Trailblazer Award in 2016. She's still active in the school's affairs. She's a parent. She's on the board of management and the Parent Teachers Association's executive. And she's a member of the Christian Life Fellowship, where she's in the children's ministry. Dr. Knight-Madden will be talking to us today about cross-Caribbean clinical gaps in hereditary blood disorders and what we need to do. You're welcome.
Thank you very much.
Yeah.
For the introduction, Dr. Ikolo. Thanks to the organizers for including me in this panel discussion, this webinar, and thank you to all of you who are attending. So I'll be talking a bit about cross-Caribbean clinical gaps in hereditary blood disorders and what we need to do. So I'm pretty sure everybody here knows about the Caribbean, but I'll quickly introduce the region and then talk about sickle cell disease in particular. That will be most of the talk, and then a few words on hemophilia, thalassemia, and other inherited blood disorders. So, we're all here in the Caribbean Sea, and we speak a variety of languages. And remember, if you joined after the introduction, if English is not your primary language, you can go to the button at the bottom of Zoom and get captions in your language of choice. So the regions vary in political status from being independent to being parts of other countries. And this is important in terms of the care that people get for these diseases. The ethnicity is mixed, again, very relevant. And we have, for us, big Cuba, over 11 million people to, less than 5,000. And this is important because in a very small island, you may not be able to actually have a sickle cell center, but you still need to have access to standard of care. And this is a big one. The economics vary a lot. So, the French overseas territories are part of France. I don't have their per capita income here, but in terms of independent nations, we vary quite a bit from 38,000, which is not bad at all. That's actually a high income country to very poor countries. All of those things affect care. Now, the genetic underpinnings of these inherited blood disorders in the Caribbean come out of our history. So we know that many people came from West Africa because of slavery to the region, bringing the sickle cell genes with them. And also sickle cell genes came from India, double whammy, as well as the thalassemia genes. And in terms of hemophilia, it's said that Queen Victoria may have been a carrier and have given this to her various progeny who became royalty in, Russia, Germany, and Spain. So I'm going to talk a little bit more about the regional situation. And of course, we're going to start with CARES, which has been introduced by Dr. Ikolo. So I've been a part of CARES almost since inception, and I'm a vice president now. And this is quite a template for the Caribbean because it's very unusual to have organizations that are multilingual and that get on and are sustained in their activities. And these are just the members of the executive. We have members from other areas as well, including South and Central America. But what is important about CARES is that it is open to everybody. Membership is open to everybody. So there's no reason why every island should not be represented. You just need to go to the CARES website. It's there in English and French, and become a member and become a part of the activities that are going on. So as I've said, we've a model of multilingual integration for health promotion and research. And we've published quite a bit and had, postdocs going from one place to the other, had research going on in different countries. And this is important. Now, in terms of the activities of CARES, one of the main things has been this aim to have newborn screening for sickle cell disease across the region. So there's some long existing programs in Jamaica, the French overseas territories. Cuba does a prenatal testing, excellent program. And St. Lucia has been testing for a long time, but it's not universal. And then we, as CARIS, had some newborn screening programs. Tobago's long-standing, comprehensive for their universal, and well integrated into the work of the Regional Health Authority. And then there are places where we've done some screening over time: Grenada, Dominica, Antigua. We've done a bit in Trinidad, in Haiti, and St. Lucia through Jamaica, and the STI, which I'll come to. The problem is that until and unless it's integrated into public health, it doesn't become sustainable. So one of the main things is to convince people that right regulations and guidelines and laws, that this is important. CARIS has also done training. We've had conferences. It used to be every other year, but then COVID, as I said, research. And then we have the scorecard. Now, this is the link for the scorecard. And right now we have 4 countries, and we hope to have very many more. It talks about, governance, newborn screening, early childhood care, chronic care, research, all of those sorts of things. And what we want is, regardless of the state that your country is in, let's get it on there, because we want to use this as a tool to advocate in CARICOM, to say, there's no reason why your country should be so far behind other countries in the region that are not any better off in terms of financial standing. So please, if you're not aware of the scorecard, make a note of the URL and visit it. So now I want to talk about the Sick Kids Caribbean initiative. So this was an initiative coming from Sick Kids, Hospital for Sick Children, where I trained, to 6 of the largest English-speaking countries where there were contacts. And so it was easy to initiate and sustain collaboration. In the first iteration, I worked with Isaac Odami, looking at newborn screening. And for a while, we did screening in St. Lucia, where the samples came to Jamaica to try to move to a more up-to-date form of testing, HPLC, rather than the CAM and AGAR. But that was just a temporary project. But SCI has done a lot of things. Now it's in a different phase. It's basically they're raising money so that they can continue to train people from the Caribbean about cancer and blood disorders. But it's been handed over fully to the Caribbean partners. But there's been a lot of impact on particularly children with cancer, with oncology databases, updating guidelines, working together to get drugs and so on. But perhaps most important for our topic today is that actually 5 pediatric hem-onc specialists have been fully trained at Sick Kids, and there's, I think, a couple more there. And what we're raising money for is to be able to continue to train. More than 40 nurses have been trained in cancer and blood disorders at UA in Trinidad. So SCI has really partnered in the Caribbean to make a big difference to the treatment of children with blood disorders and cancer. And there have been facilitated collaborations there's one ongoing about transfusion, about hemophilia, and so on. And then we come to Jamaica. So this slide, I'll tell you what, this is what made a difference. Having a specialist center, having research, all of this kind of stuff was very important, but it didn't move the dial for the child born way out in Portland or out in Westmoreland. What moved the dial was when sickle cell disease was included in the National Non-Communicable Disease Strategic Plan. It became policy that we should train our healthcare workers to manage sickle cell disease, that we should have guidelines available, and that we should screen babies and pregnant women. Or we were screening pregnant women for before I was born, probably. But the newborn screening was new. So that we were so naive. We said by 2015, although by the end of 2015, we had done most of the public hospitals, and since we have included the private hospitals. So it's pretty much universal now. Not to say you can't miss a few babies, but it's there. But what is the problem is to make sure that those that are identified come in to be confirmed and get into care. But it's a big, big deal because in the old cohort run by the sergeants, you can see that by the time this is a survival analysis, when somebody dies, it goes down. That by the time they reach to 20% of the babies with SS were dead. And this is in Jamaica about 40 odd years ago. With starting just vaccines and penicillin, you can see that's the difference that was made in that same cohort, so maybe 30 years ago. And then this was at the unit a few years back. But what we're seeing is that just identifying babies at birth and giving them very cheap stuff, penicillin, vaccines, and care can make a huge difference to survival. In fact, no, if a baby is born, diagnosed at birth, and managed in a comprehensive care clinic, then their 5-year survival is the same as the rest of the population. So this is what we need to get out there. And then, of course, we want to add in things like hydroxyurea. And this is what is the engine behind it. So the Ministry of Health chairs it. The Family Health Unit, which does newborn screening and early childhood care, NCD takes over then. The Public Health Lab, the regions that deliver the care, the labs, the unit in terms of research and clinical care, and of course, our patient who helps to really guide what we do when we do. So there have been policy wins. I'm not going to talk about that, but the important thing is that you don't have these silos anymore. Everybody's on the same page, around the same table once a month, trying to advance the care for sickle cell. And I think that's the secret to success, having the policymakers, academics / caregivers, and patients and their families and advocates together so that we can have light all over the island and indeed all over across the region. But where are we now in the Caribbean in 2023? If we do the steps up to where we want to end up, sadly, a lot of countries are in symptomatic diagnosis. So it's when the child or adult gets sick, they get diagnosed and get some therapy. In some places like, Trinidad and Tobago, you have localized newborn screening primarily in Tobago, and those children get comprehensive care. In Jamaica and the French West Indies, universal newborn screening and comprehensive care. We are trying to make this step in Jamaica. We're actually doing a study now to understand what are the barriers to using hydroxyurea. Why is it not used more widely? Because hydroxyurea is relatively cheap and makes a big difference in most people with sickle cell disease. Not to say we're not interested in the cure. We've actually been a part of a trial on the gene transfer, which was very helpful to our patients. And there's a lot happening in that space right now, but it's still experimental. It is still experimental. What is not experimental is bone marrow transplant, which is not available except in the French Caribbean. They're sent to Paris. And some of the other treatments are very expensive, and we would need to make sure that we have covered, that we crawl before we try to run. So let's make sure we have these things in place before we necessarily ask our policymakers to move to very expensive therapies. But there are gaps. In most of the countries, no policies, no laws, no active collaboration within the country between these three groups. And as a result, a lack of access to basic care for some of the people born with sickle cell disease. On to hemophilia. Now, the World Federation of Hemophilia is a great support to our region in their efforts to have treatment for all. So we do get products from them, which are used for the patients who are affected, but that is the primary source of these products, at least in Jamaica, rather than coming through our own ministries. So if you go onto their website, you can see, you can put in the country and it will bring up who is the contact. And you'll see that for Jamaica, it's Dr. Wolf, who's now retired. And I think she's handing over to Dr. Wokocha, a younger hematologist. And they are actually at the Federation's conference now in Panama. And it is my hope that they are getting together while they're with other Caribbeans so that we can talk about how we can move forward as a region. So you can see from the country profile that based on our population and the expected prevalence, there should be about 250 cases, but we are aware of less than 100. So they're either the genetics is different or we're not diagnosing people, and so they're not getting care. So this is a problem. So there are 4 places that you can go, 1 for diagnosis and treatment and 3 others for treatment. And, you know, the doctors are the hematologists. So it's not a lot of them, less than 20 for the country. So this is part of why they don't treat sickle cell disease. They do a lot of cancer and these other disorders. But you can see the difference in the numbers. So whereas we expect we have about 18,000 people with sickle cell disease in Jamaica, we have a much smaller number of people with hemophilia, but it's still important and they still need care. If we see in Bahamas, Barbados, among other countries, you can see that the contacts are actually the patient groups, the advocacy groups. And in Trinidad and Tobago, they deserve special mention because they actually have everybody in one advocacy group. So hemophilia, thalassemia, sickle cell disease, everybody under one organization. So lots of gaps. The data may be missing. And we may actually be missing persons. So we don't know what's going on. That needs to be addressed because scientists need to get data so that patients can affect policy. So it's easier for patients with lived experience and stories to move policymakers than for scientists with their data, but both are required. And then we need collaboration within the country, between the countries, and access to basic care that's not reliant on the World Federation. No, I can't say a lot about thalassemia. They're cared for by the hematologists. In Jamaica, we don't have as many people affected as they would in Trinidad and Tobago and Guyana, where the mix of ethnicities is much different, where more than 50% of people would either be primarily Asian or mixed origin. And so they would see a lot more thalassemia. The diagnosis, sometimes we diagnose obviously traits and so on as or compound heterozygotes, S beta plus, S beta not, but we do not diagnose thalassemias in our newborn screening program. And I suspect that's the same across the region. As you heard, there are other inherited blood disorders like von Willebrand's disease, G6PD. We diagnose the hemoglobin CCs as part of our newborn screening program and send them to hematology. These are small, very, very small numbers. And I suspect that there's no organized way of treating with this. So the usual gaps: data, policy, collaboration, so that all can have access to care. So in conclusion, in terms of identification of these disorders, treatment options, and support, sickle cell disease is by far the most common and has had the most attention and progress. But programs should be in place for all of the inherited blood disorders, and data are required to lobby policymakers. Thank you.
Thank you, Professor Knight-Madden. Thank you, everyone. So we'll move on to the next section, which is questions and answers.
Okay, I can take the first question that I see in the chat. Do we know the cost of gene therapy replacement treatment for sickle cell disease? As I said, it's experimental. It's extremely expensive at this point. There's no question about it. but it is still experimental. One good thing is that there will be competition. So there's competition in terms of the different approaches. So whether or not people are using CRISPR or they're using taking out the stem cells and doing the insertion of a gene, which is what we did in the study that I was a part of. So usually if there's a monopoly, it tends to be more expensive. But if there's several people doing it and there's some level of competition, hopefully that in itself will help the price eventually not to be as high. But it is experimental. All right. So it's not that you can go out there and if you had
money,
$1 billion, you can just go out there and get yourself this treatment. You would have to join a trial because that's the only way you can access it right now.
Yeah, that's right. The first person who was treated with gene editing, Miss Victoria Gray, she was treated, cured. She received her treatment 4 years ago in the United States. It cost millions of dollars. So like Professor Knight-Madden said, it is really expensive. However, with time, we will see the cost coming down, just like initially when sequencing of the genome started, it used to cost millions of dollars. But now, because of competition, sometimes the companies even offer specials that with a little under $100 you can send your sample down to the lab for sequencing. So we are hoping that that type of transformation can take place over the years for the blood disorders, the hereditary blood disorders. Thank you, Professor Madden.
So in the Q&A, she has said, Dr. Hardy de Sousa has said that she's sorry that she missed part of Dr. Ikolo's speech, and that as far as she knows, the latest news from Grenada is that the medical director of the Ministry of Health wants to set up screening in Grenada to continue the screening carried out in Guadeloupe with the support of CARES.
So, yes, I'm aware of that. I'm aware of the fact that we've had newborn screening in Grenada for some years, but because of funding, this discussion was taken to the Ministry of Health, who is supporting the continuity of the program. So the program, the newborn screening, will continue with the support of the Ministry of Health in Grenada for some time while we look for funding from external agencies. The Ministry of Health is ready to support the program to continue. So thank you for that.
So one of the things that we need to think about, and I'm coming to that question from our friends in Trinidad and Tobago. I really hope that we are able to unmute people so that they can speak, because we will certainly lose some of the richness of this if we're not able to do that. Based on the directions we received as moderators, it sounded as if we would be able to do that. So as we go forward, it's a little different. When we went universal, we used high throughput liquid chromatography, HPLC, and we got help from all over. So Brazil actually donated a machine, south to south collaboration. And then one of the private sector companies gave us money from the largest 5K in the region, as well as, CARES pitching in and so on. So we have this machine. It is relatively expensive as the methods go. There are some other methods that are less expensive, but it would have been difficult because of logistics. Now, what has changed in the last 10 years is the point of care testing has become more available, has decreased in cost, and is relatively sensitive and specific. So as countries move forward, one of the things that we should be discussing is whether or not we'll be using point of care tests and whether we will be accessing them as individual countries or as a region. Is this something that we can take to PAHO and ask them to order on behalf of the region in the way that they order vaccines? Can they order hydroxyurea for us on a regional basis in the way that they order vaccines? But that would require us coming together and talking and discussing and being in agreement to make a presentation to them about that sort of thing. If people are interested in that area, we can discuss it more. In terms of responding to my friend from Trinidad and Tobago, CC is a mild hemoglobinopathy. They can have splenomegaly, they can have a mild hemolytic anemia, and so on, but it is not as severe as sickle cell disease, but certainly does need chronic care.
Yeah, I agree with you that there's the need to engage both regional and international organizations to access funding for projects like newborn screening. You mentioned that the machine that you use is pretty expensive. So speaking to an organization like PAHO would be beneficial, WHO. And one other thing that we can benefit is like even in the region, within the region, I know that for the newborn screening program in Grenada, before it started, CAREST was involved in the initiation of the newborn screening program in Grenada. We will benefit from such organizations like CAREST working with countries like Grenada and other countries in the region for the continuity of the program. For now, in Grenada, like I mentioned, the Ministry of Health is coming in to ensure that the newborn screening doesn't stop. However, funding is welcome from regional organizations, international organizations. The question is, how do we engage in the region to ensure that we get this funding?
Oh yeah, so maybe you misunderstood me.
Yes.
I wasn't saying that. So Brazil helped us with a machine. They bought disposables for a year, and then the government of Jamaica, through the Ministry of Health, is paying for it. Okay, and CAREST, bless CAREST, it's taxpayers' money from France. We can't expect that in a long term. They have helped so much by providing data. So if they screen every baby born for 2 years, you have your data. You have your data. It's then up to the country to convince the Ministry of Health to pay for, to make it a sustainable, integrated program within that country. We're not going to be able to get anybody from outside to pay for a long-standing health program like that. That's very, very unlikely. What we have to do is get the data and try. And this is why I say these three together, the patient and the advocate, that is who moves the politician. It's not the scientist that moves the politician. It's the patient with their stories, right? And then the scientist and clinician who provides data and provides care, and a policymaker. We need somebody, maybe, depending on the country. I mean, in some small countries, it might be the CMO themselves, it might be the PS themselves, but it might be a departmental leader or something. But you need those three people to agree, come together regularly and try to push the agenda forward. So when I was talking about PAHO, I wasn't talking about PAHO funding HU or funding point of care. How it works for vaccines is that they order across the region. So they actually get a better price because they're ordering more, and then the governments pay for it. So the governments pay into the fund and get vaccines out. It's not that fast providing the vaccines. What they're providing is a vehicle which allows the governments to get it for less. But
yes, I understand that.
The budget of the government.
Yeah, but because of
where we have to be moving towards.
Yes, because of the power in numbers, right? We can actually benefit from such support from organizations like PAO. Because sometimes if we want to do some of these things individually as individual countries, it becomes it sometimes is difficult because of number, how like the vaccines you're talking about. How many are we going to be buying in a country depending on the population? But if we do it together, it becomes easier. So I agree with you that PAHO can support in that respect. Can we ask for questions in the chat? Any questions in the chat? You can type your questions in the chat, please.
One of the issues that we've had is really that sickle cell disease hasn't been acknowledged in many places as being an NCD. We know what the big NCDs are: hypertension, diabetes, asthma, mental health, and so on. But actually, sickle cell disease in places with high prevalence is a very important NCD, because remember, although it is genetic, it is certainly chronic, right? So persons with sickle cell disease live way longer. Here, I see a hand up. That's Mr. Young. Can you please unmute Mr. Young for me? So although survival has improved, so our median survival in Jamaica for persons from the cohort would be somewhere in their mid to late 40s. I would expect that the persons being born now would have even better survival. But certainly people are living into adulthood. The vast majority of infants born with sickle cell disease in Jamaica are expected to live into adulthood. So what are we doing in terms of the NCD? Because they certainly get renal disease. It's one of the top 10 reasons for dialysis. They have chronic leg ulcers and so many other chronic organ injury problems that indeed they have a non-communicable chronic disease. In certain parts of Africa, sickle cell disease is acknowledged as an NCD. This has been encouraged by WHO Africa. And in Jamaica now, it's acknowledged as an NCD. This is important because if you then make a policy for NCDs, it applies to sickle cell disease. So if you're going to have an annual day observance for hypertension, diabetes, so on, so now the Ministry of Health leads and funds most of World Sickle Cell Day observances and also supports our Sickle Cell Awareness Month. If you're going to have a website for NCDs, it has to have a tab for sickle cell disease. So if you go onto the Ministry of Health and Wellness website for NCDs, you will see a tab on sickle cell disease. If you're going to have a series of training, so we had an ECHO program put on by the Ministry of Health for NCDs. So sickle cell disease was rostered among the other NCDs, and we did our part of the ECHO. So when I suggest that you may want to advocate for your country to recognize sickle cell disease as an NCD, it is not a trivial recommendation, because then whenever they're paying attention to other NCDs, so we have an NCD commission that is appointed to advocate for the NCDs and look at how to improve things. So sickle cell disease is represented as a part of that process. So I cannot overemphasize the importance of policy, because especially if you are in a place like Jamaica, and I think Trinidad is like that as well, where although you have the Ministry of Health that sets policy, care is actually delivered by regional health authorities. And these regional health authorities differ, but they have a contract with the Ministry of Health based on policies, based on deliverables. And ever since sickle cell disease was added to the NCD list, then the number of deliverables that the RHAs have to do based on sickle cell have increased. And so the coverage for newborn screening, that is something they have to report on monthly and annually because it's an NCD.
Like you said, Dr. Knight-Madden, registration of these disorders within the NCD is something we will take home. Everyone here should take home to our respective regions, our respective countries, to advocate for this to be done, considering the importance and based on what you have said, on the strides you have made in Jamaica with having this done. But one other issue, one other area, or one other reason why some regions may be having difficulty, I will say it and I will leave this up for discussion by everyone. Stigmatization of those who are affected. How do you see this in your country or in your region? Those who are affected feeling stigmatized, not wanting to come out to be tested, or I'll leave this open.
Okay, that's a very good question. Ms. Clauden, please put in where you're from. Thank you for that response that you spoke to the epidemiologist on this issue recently. Please just say where you're from. Thank you. Yes, we would love to know what you think of stigma in your country. Mr. Young is going to send comments because he was unmuted and speaking, but nobody was hearing him. So there's an IT issue. So he's going to send us some comments. So I would really request that everybody who's on, we're having some problems with our IT, not able to hear people. But please, we need to hear from you, if not orally. Can you please get talking with your fingers and type some comments for us so that we can know what's happening where you're from? Dr. Ikolo has asked a very important question about stigma. So if you are aware of stigma in your location, please go ahead and type in the chat.
We have Nurse Claudine has written in the chat. I know her very well. She's from Grenada. Nurse Alison Claudine. She's involved in the children's monthly clinic that is offered in Grenada. She's a volunteer, a member of Sickle Cell Association of Grenada, very active member, Nurse Alison Claudine. So we are still...
A monthly clinic is not to be disparaged. A monthly clinic is an important step forward, because at that clinic, you can do your vaccinations, your monthly penicillin, you can do your talks. So, while the patients are waiting to be seen, you can have educational talks about how to feel the spleen, this and that. So a monthly clinic is a big step forward, and you all are to be congratulated on that.
Thank you. Thanks to Nurse Claudine, who is one of those responsible for running the monthly clinic in Grenada. And vaccination is one of the penicillin from a very young age, vaccinations, talks, checkup, those are some things that are offered in the monthly clinic in Grenada. So we are still hoping that you can tell us about stigmatization for those who are affected in your region. I see 2 hands up.
Just taking these questions out of the chat because they have been dealt with.
In terms of stigmatization, that is one of the areas that Sickle Cell Association of Grenada has been trying to, over the years, to enlighten people about sickle cell disease. And I will say that the association has made great strides in that area, because before, some people used to believe that if you sit close to somebody in a bus, for example, that has a sickle cell disease, you may catch it. But because of public enlightenment campaigns that have been organized by the association, most people in Grenada know that it's hereditary, that is passed on from parents to offspring. So stigmatization is an issue. And in addition to that, the public enlightenment campaigns have also been reaching out to young people, because most times you will see that the ladies, right, women are, you get them to test more easily than the men. But by organizing health fairs, Sickle Cell Association of Grenada, for example, is prominent in health fairs all across the country, where young men generally are advised to test. Some will say, I'm no longer having children. Even women may say, I'm no longer having children, but they are still encouraged to test to know their status, whether they are carriers or whether they are carriers or not. So these are some of the areas: testing, public enlightenment campaigns, health fairs that help in this area.
Okay, thank you.
Okay.
Seeing
Yeah.
some comments there.
Yeah.
So Nurse
Yeah,
Clauden is saying that
Dr. Mondale George. Yeah,
Dr. Mondale has said that stigma is improving. Our own, we've done quite a bit of stigma research, particularly Professor Asnani. And it's funny because in a lot of places, they think that the stigma is all because people are visible minorities. So you're Black or Asian and you have sickle cell disease. But in a country like Jamaica, where most people are not white, then there's still stigma because of the jaundice, which, if it's not sickle cell, is likely to be catching. So this is where it comes from. The leg ulcers, which can be quite unpleasant. But one of the big areas of stigma that we have to deal with is stigma in healthcare providers, who see many people with sickle cell disease as addicts when they're not. They're appropriately seeking pain relief for their very severe pain. And so I'm going to put in the chat an article. We actually did a needs assessment study where survey. We looked at adults with sickle cell and parents of children and asked them what were the problems and what were the needs, what were the challenges. And it was, you couldn't read it without crying when you hear how people have been treated in A&E and on the wards. And so we have reached out to the Association of Emergency Physicians, and we've had a session with them. We hope to have others, but that wasn't at the top of our agenda as a technical working group, but we had to put it at the top of the agenda because that was at the top of the patient's agenda. Yeah. And so one of the things is to find out what is happening with the patients where you are and try to address that. There are some basic things: newborn screening, early childhood care that saves lives, so children don't die from pneumococcal sepsis and acute splenic sequestration. But the stigma can be terrible. People will be at home suffering rather than to go to the hospital because of how they think they're going to be treated and how they are treated sometimes. Yeah. And so it's important that we continue to do that work of explaining to patients time is almost up, but let me give you one example. Pethidine. So if you give IM pethidine and you give 60 milligrams, and then you say, oh, they're doing better, let me switch them to oral, and you give them 60 milligrams of oral pethidine, it's equivalent to 10 milligrams of IM. So you've gone from 60 to 10. No wonder the pain comes back. But a lot of people actually don't know the pharmacology of the drug and don't know that. And so they assume that it's because they're addicts and they want injections. Who wants injections? Why they're acting like that? But the pain has rebounded. So we have to teach the knowledge about sickle cell disease as well as going to the heart of why is there stigma and trying to demystify what's going on so that people no longer suffer from that kind of stigma. Yes,
and the teaching
I'm answering a question here. We also have problems with employment because you get sick. So in the recent sickle cell awareness campaign that we had for September, I did a lecture. It's online, and I actually had an employee and a supervisor talking about how you can make it work. But it takes honesty. You can't hide your disease because then when you're absent, there is no compassion, right?
Yeah.
But you have to find an employer that is willing to work with you. And the employee that was on, what her supervisor said is that she works so hard when she's well, that even if she's sick sometimes, she's doing as much work as anybody else.
Yeah.
Right? So this is what we have to do. You know, like when you say, if you're in foreign, you're a Black woman, you have to work harder than everybody else to get where you're going. Well, when you have sickle cell and you have a job, you have to work that much harder to make sure that you're so valuable.
Yeah. Yeah. I agree with you. The teaching, that means the teaching we are talking about should be both for the lay person, both for the practitioners, right? Both for practitioners in the medical field have to be more enlightened about the needs of those who are suffering from sickle cell disease and other hereditary born disorders. And Dr. Mondale George also wrote about stigmatization for relationship. Those who are affected may have difficulties in finding partners, for example, because of stigmatization. So this enlightenment campaign, you know, a lot has to be done.
Well,
if someone feels, oh, if I get married to this person, the person is going to die just now, they have sickle cell disease, I won't marry the person. What do we do in these circumstances? Enlightenment
we do need to make sure that people know their own status, because you don't want somebody with sickle cell disease marrying somebody with a trait.
That is true. That is true.
Right? Because then they have parent and children with the disease, and that's very difficult. Yeah. We do have one couple of SS and SS with lots of SS children, and it's really incredibly difficult. Yeah. So people with sickle cell disease should be with somebody who is AA, no thalassemia trait, nothing else, so that their children will be fine. And again, don't surprise people. Don't make them find out long after you're married that, oh, you have this problem. Yeah. I remember in the chat, because in about 2 minutes, they're going to send out a poll survey about how the session went, and we will be asking you to fill it out. So Mr. Young is saying that an aging population with sickle cell contributing to suboptimal outcome in this area is relatively new. We must always work beyond the call of duty, yes. And the fact that we have aging patients is a positive thing. It means that people are living longer and being better able to work at fulfilling their purpose, and that's a wonderful thing. But yes, we have to work at it. We have to work at it. Ongoing, I see another comment, ongoing education and training of our healthcare providers is key for care. Yes, yes. And then we see coming from, not sure where it is, that the Caribbean is well poised to lead recognition of sickle cell prevalence in Jamaica is high. Globally, yes. In the Caribbean, it's second only to West Africa. Grenada has first person diagnosed with sickle cell. Trinidad has the Joint Society for the inherited serious blood disorders. And we have IVDs for awareness advocacy, maybe one globally. So maybe we can attract some funding. We can look to attract funding. We certainly can look to attract funding, but I really believe our first call is to make our governments take up their responsibility to our patients and give good care.
Just before we wrap up, on a final note, you mentioned that in Jamaica you have a couple, both of them have sickle cell disease. I remember there was some years ago, Dr. Sargent from Jamaica came to give a talk in Grenada, and he mentioned that situation to us. How do you handle the situation where you have two individuals, they know they are affected and they say, okay, we don't mind, they still want to go ahead to get married, to have children, while counseling is going
no
on?
way of handling it apart from education. And I think everybody from the driver to the nurse to the med tech to the doctor to everybody in the clinic says to these people, what are you thinking? You have one baby and then you have more than one? Because those babies can only come with sickle cell disease.
Yeah.
You know, but they did not meet at the clinic. They went out into the wide, wide world and met each other. But when we have our teen camp, which I hope we'll be able to start again now that COVID is less prevalent, we take our teenagers and we teach them life skills and we teach them about sickle cell disease and self-worth and purpose and all of these kinds of things. But I am not involved in the camp. That is Dr. King's baby. But the one thing I go every year and says, please don't fall in love with each other. Come to camp every year, but do not fall in love with each other. And it's
the camp,
yeah. Cystic fibrosis camp in Canada.
Oh.
Right?
Yeah.
So
poll is up.
The poll is up. Please do go ahead and I see that somebody saying that their chat is not working. We do apologize for that. Go ahead and answer the questions as we bring this to a close. Again, I would like to thank all of you who have joined for participating. But we do hope that you will continue to participate in the rest of the today's seminars and tomorrow's and make the most out of this opportunity to interact with global experts and with people affected by these diseases from across the world. These are really important undertakings, and they're not trivial undertakings. They take a lot of funds, they take a lot of planning. So we really want to thank the organizers and encourage you to make the most of your registration to listen to as much as you can. So if you would go ahead and fill out the poll.
The poll, yeah. So thanks again. I want to add my voice to thank everyone for coming. And I look forward to our working together in the region to make it better for those who are affected. And I also want to add by thanking GANSID for organizing this Congress. I will say that by communicating with different organizations in the region, I've come to understand better how some organizations like Trinidad having a comprehensive organization for the different disorders, the units in Jamaica. So it has been really helpful to me as an individual, and I believe so for most people or everyone here. Thank you so much to GANSID for this Congress. And thanks again to everyone for coming and for your comments, your suggestions, and for your time. Thank you, Dr. Knight-Madden, for a wonderful presentation.
Thank you, Dr. Ikolo. It's good to be with you in this panel, and I look forward to talking with all of you in Grenada and other countries bilaterally, but also through CARIS, and encourage all countries to get their data up onto the scorecard so that we can use it to lobby our governments to say what is possible in our region. Even if we are LMICs, some of us are high income, but even if we're LMICs, we can do better.